in there, but it's
All right, so we're gonna get started here. Today is your first exposure to Kelly Tillotson. She's a fellow with us. I'll let her introduce herself further here momentarily, but enjoy. Thank you, Kelly.
Thanks. And then Richard's feel free to jump in anytime, but.
Yep, absolutely. No, Kelly, we're looking forward to having you join us for the year. It's a great group. We've already talked about it. You've kind of got your introduction from Chief Whitty over here, and we look forward to it. So we're throwing you in on your first month with us for CQI, so you get to lead it. And obviously, it's a good case we're talking about. And I'll turn it over to you for further intros and all the rest. We're really happy to have you for this year.
All right, cool. Thanks, guys. Good to see everyone. I got to go riding around with Chief Whitty a couple of days ago, and it was really fun to go see Westchester and see all the different houses. So I'm excited for this year. So yes, I'm Kelly Tillotson. Please call me Kelly, or KT. Either one is fine. Hey, you is also acceptable. But I am the EMS fellow this year. So I'm working on my tour from the Midwest. I'm originally from Stevens Point, Wisconsin, which is like small town, kind of on the border between the Northwoods and civilization. So grew up there and then ended up going to college in small town in Michigan, Hillsdale. And that was my first big exposure to EMS, where I got my EMR and did a ton of volunteer ride time with their third service agency, doing 911 calls and transfers to some of the larger cities in Hillsdale. So that's where I got my bug for EMS, but by that point I'd already matched in medical school and realized it was too late. So went to medical school in Milwaukee at Medical College of Wisconsin. And that was where I got my first like urban exposure, going around with Milwaukee Fire Department. And the first couple months when I moved down here, I accidentally called CFD, MFD multiple times because I was changing cities and got corrected very quickly. So but came down here for residency in Cincinnati and then sticking around this year as an EMS fellow. You guys may have seen me flying around on the helicopter or may still see that. I was one of the flight docs with UC Air Care and I was their medical director last year. And the bottom picture here is when I made it to 100 flights about halfway through my last year. So working on trying to get that number up. I really enjoy flying on the helicopter, doing critical care transport, and I'm very excited to get some more work on the ground side of things because that is one area I think you guys have a lot to teach me on. Also spend a lot of time on Cincinnati SWAT, which they love when the 5-foot tall girl comes around carrying a backpack that's bigger than she is. But when I'm not at work, my family is still in Wisconsin. I go try to visit them whenever I can. My two younger sisters are in music and psychology respectively. And then those are my nephews, my fur nephews, Augie and Beckett. And hopefully we'll be getting my own fur baby sometime this year. But looking forward to spending time with everyone and going around doing some crazy stuff in Westchester. Also, I love to teach. Please feel free to ask me questions and please feel free to help teach me about the fire side of things as well, because that's something I don't have any exposure to and would really love to learn about. All right, let's get into it. So the big case that we're going over today is one that I'm sure you guys have probably heard about, but the chief complaint for this patient was a choking patient. The fire department was dispatched for a person choking, and when they arrived at the nursing home facility, there was an elderly female who had been eating dinner, which was, I think, shrimp and sweet potatoes, and she had been turning blue and was not able to respond appropriately. She had been having the Heimlich maneuver performed without any success for her. When our group arrived, they noticed that she was cyanotic and having difficulty with ventilating her and using a BVM. The time course that I have for this case, the discussed that they got there, tried doing airway clearance, Heimlich maneuver, and ended up trying to bag her and give supplemental oxygen, and also placing her on end tidal monitoring. NPAs were placed. I think there was difficulty with passing one of them because the patient had a fair amount of edema on her face as well, and IVs were placed on the patient. There was an attempt at oral intubation from above, but due to a significant amount of swelling, there was difficulty passing the tube. And at one of the points when the tube went in, there was some return of food contents, particularly the shrimp, that was attempting to be sucked out of the airway. Unfortunately, while all this was going on, patient ended up having worsening oxygen saturations going down into the 70s and the 60s, and having difficulty getting her to be bagged up. And also at this time, there was a very high end tidal CO2 reading. I believe it was in the 80s. And thus the decision was made that this is a patient who they could not oxygenate and could not ventilate. So the decision was made to proceed with criking the patient. So you can see on the timestamps, there was an attempt at using the control cric kit And there was successful placement of the Crike device with return of end-tidal CO2 that was appropriate, but there was a ton of resistance to bagging. So at that point, the device was removed and a second attempt was done using a bougie-assisted Crike, which we will talk about as well. And with that, again, there was still return of, there was still oxygenation ventilation with that, but patient was still hypoxic on the report. Medical control was contacted, and while that happened, because they were still having difficulty with bagging the patient, the device was swapped back out to the control right device. And at that point, huzzah, we now successfully are bagging the patient and things are working a little bit better. Patient was at that point getting ready to be transported out to the ambulance and then to Westchester Hospital. And one of the concerns is that during all of the airway management here, they tried to look for a food bolus because the patient had been eating dinner and the assumption was there's got to be some big food bolus that's preventing us from actually being able to oxygenate and ventilate this patient. And despite multiple attempts to look and remove it, there wasn't any, but there was significant airway edema. And there's some thought that potentially the food components that were present in the airway might have been from aspiration as part of the Heimlich maneuver. So the other thought too was, is this angioedema versus is this anaphylaxis? So that was part of the reason that IM epinephrine was given to the patient to try to help with some of that airway swelling. While she was in the rig, 12 lead was performed that showed that she had some sinus bradycardia. And then unfortunately, shortly after that, patient went into cardiac arrest. And that was about the time arriving at Westchester Hospital. So going through the narrative that was written for this patient, which is a pretty long narrative for a typical ground run. A patient they were trying to bag her, noted a little bit of wheezing bilaterally, but there was not a lot of air movement in the lower lung fields. Tried to put the NPAs in, didn't have a huge amount of improvement. GCS had diminished significantly where the patient's eyes were open, but having no verbal response and then no motor responses at all. Attempted to do direct laryngoscopy with no food bolus visualized, but did notice this tongue swelling and concern for some other inflammatory response causing the difficulties for this patient. They were not able to get the tube fully in further, and due to the patient not being able to oxygenate and ventilate, then decided to proceed with a Crike. I talk about that the Crike location was successfully located on the patient, suctioned the blood from the insertion site, but there wasn't great air movement after placing the Crike. However, there was end-tidal recording that shows that they should have been in the correct anatomic location for it to have it in the actual airway. Then swapped it out to a bougie-assisted Crike with a 6.0 ET tube with a little bit of improvement, and then ended up shortly thereafter while calling medical control, the device was swapped back out to the typical Crike. And noticed that there was a little air return with some bubbles present. And the other thing that I learned talking to some of the providers on this case is that while this was happening, there was also a significant amount of crepitus that was happening in the patient's upper torso. She was kind of described as looking like a balloon by the end of all of this between the edema and some of the subcutaneous emphysema. A patient was placed in the ambulance, CPR initiated, and taken to Westchester Hospital. Lauren was able to get follow-up information for this patient. When she got there, there was crepitus as well as patient having the Lucas in place, getting she was getting chest compressions in place on Westchester's Lucas device. Was managed by ACLS protocol, and they did end up getting ROSC for the patient. At that time, they attempted to look from above at the hospital to attempt to intubate orally again. And this time they were successful with a very small endotracheal tube, a 5.0 tube. And at that point, also had the patient regaining her pulse as well. Then they ended up going to upgrade to a 7.5 endotracheal tube and having some improvement in the patient's overall respiratory status. They ended up having her admitted to the ICU, and then again, due to some of the current concern for potential anaphylactic versus angioedema setting for the patient, was given steroids via Solu-Medrol and then also Pepsin. While patient was in the ICU, family members ended up deciding to withdraw care on the patient, and she passed away shortly after being in the hospital. So, yes, we're talking about the Crike case. So first of all, any questions or thoughts after going through the case from everyone?
So I don't think I fully realized, so I know that we did the Crike kit, the prefab, and then did the 6 over bougie,
Mhm.
and then tried that, and then exchanged that out, probably with the bougie in place, and then put the.
And then put the commercial device back in, yes. So other than the pucker factor for people, I actually think looking through the documentation for this, I do think this was a justified cric on this patient, given everything that was going on for them. And this is a fairly rare thing that happens in the pre-hospital setting, even some of the literature that I looked into, which is why we're gonna talk about it today. So first of all, we'll just do a quick discussion about the difficult airway, which a cric is kind of at the end point of that. Unfortunately for us in the pre-hospital setting, we get to manage difficult airways with not a lot of information and oftentimes without a lot of time for critically ill patients. The critical things for airway management is that your patient must be able to oxygenate, ventilate, protect their airway, and be able to manage whatever is coming up in regards to the rest of their clinical course. So they must, and as part of each of those goals, those feed into the decisions to take away a patient's airway. So say if you have a patient who, despite supplemental oxygen attempts via nasal cannula, via a non-rebreather, or via bagging, CPAP, BiPAP, et cetera, if those fail passively externally to give a patient supplemental oxygen to maintain their oxygen saturations, at that point, that is one of the indications to proceed with intubation to provide kind of internal positive pressure oxygen supply to the patient, as well as higher concentrations of oxygen supply to the patient. Similarly, if you have a patient who cannot ventilate, meaning they cannot blow off their CO2, you can proceed then for them with doing assisted ventilation. It's usually done with CPAP or BiPAP. Or if they have, say, opiate overdose, we give them Narcan and make their brain wake up and start breathing again. If that does not happen, or is not happening in a rapid enough pace for patients, oftentimes we need to take away their own airway and start doing ventilation internally for these patients to help improve their ventilatory status. In regards to airway protection, this is usually things such as a poor GCS, where the patient is not going to be awake enough to protect their airway from secretions or from vomiting. Maybe an obstructed airway, such as patients who have angioedema, have masses in their mouth, have significant trauma to the face or to the neck that's causing compression on the airway. And then the last one is a soiled airway. So things such as significant hemoptysis, hematemesis, emesis, et cetera. And the clinical course, this is usually the one that people will sometimes, you'll see debate over. But usually you can think of this in patients where they have expected worsening of their mental status, or you're actively seeing them have worsening of their mental status. So a patient with a hemorrhagic stroke that is starting to herniate, and over time they're starting to become less and less responsive. Patient with worsening acidosis, and you see that you're not having success in fixing their acidosis. Other things would be such as edema to the airway, which you can see in anaphylaxis, angioedema, or in burns to the airway itself. We expect the swelling is going to continue to get worse over time, and proceeding with intubation before that swelling becomes severe can be beneficial to the patient long-term. And then another one is, say, a patient you're not able to transport safely without getting them to be calmed down. So you're a very agitated patient, either from substance, trauma, et cetera, that needs to be sedated significantly to safely transport them, but that may take away their intrinsic drive to breathe. Usually for patients that end up needing intubation, it's some combination of all four of these that ends up leading to the decision to proceed with intubation. And the reasons we hear about the oxygenation ventilation is oxygenation. We need it for metabolism for patients, particularly for their high metabolic function organs such as the lung, such as the heart and the brain, as well as muscles. Ventilation ends up being just as important for oxygenation because it removes the byproduct of metabolism, which is carbon dioxide. Carbon dioxide, as it builds up in the body, leads to a high acid state for the body, which can lead to patients having poor pH balance, leading to their enzymes not working appropriately, their organs dysfunctioning, et cetera, and also leading to them losing mental status due to that high acid content. When kind of looking at how you want to protect an airway for patients, most of the stuff that I found said that you want to make sure that you can oxygenate and ventilate them. And those may be more important than, say, having a perfect airway device in place. Like in the perfect world for a patient with a really terrible airway and kind of the difficult airway discussion for patients, you may not be able to successfully intubate them, but if you can ventilate and oxygenate them with an eye gel in place, that is okay, as long as that can be done safely for a patient. Now the problem is if you cannot do either of those things despite any of your rescue efforts, that comes into like a true airway emergency where you end up needing to proceed towards a surgical airway, AKA a cricothyrotomy. So there's actually a whole society that is like a difficult airway society that goes over this algorithm for patients. And the interesting thing when I was looking at it is most of the discussion for a difficult airway or even some of like a failed airway or an unanticipated difficult airway goes back to trying to make sure that you can oxygenate and ventilate the patient. Even if it's not perfect, you're still actually maintaining that homeostasis for the patients. So in patients where you think there's going to be a difficult airway, they talk about wanting to look with the laryngoscope and doing an endotracheal intubation from above, because that's what we're most familiar with. That's the one we get the most reps on. It's the one we've got more devices and more potential rescue methods to make it work. If you can do that, great, proceed with endotracheal intubation. If that doesn't work, one of the rescue devices that's discussed is a supraglottic device. For most of us, it's going to be an I-gel. In some other institutions, it's like a king airway as well. And what they talk about is placing that device while you stop for a second and see, is there something else I need to do to maximize this? Do I need to oxygenate them better? Do we need to change their positioning? Do we need to change our method for proceeding with endotracheal intubation, et cetera? Or is this absolutely not going to work? Patient's not improving, and do we need to proceed to a different rescue device? The other thing they talk about is if you cannot ventilate or oxygenate them with an I-gel or a supraglottic device, going back to doing a BVM, bag mouth ventilation. And I've even had like Steve Carlton say that like, if you can do nothing else, you can bag a patient to keep them alive until something else is going, until you have another backup or rescue plan. Not ideal, but something that can be done. And then last, of course, despite those efforts, you cannot oxygenate, cannot ventilate the patient. And that is where we talk about doing front of neck access, which is the cric. And in, say, a patient where you have a surprise difficult airway, kind of the same process ends up going into place, where you try going from endotracheal intubation, changing whatever you can to optimize your positioning, oxygenation, potentially even trying a bougie or a different blade for patients, trying cricoid pressure where you push down on the neck to push the airway into a view that's more readily seen with the laryngoscope in place. That fails, going potentially to a supraglottic airway device insertion, and then going back to see what you can do to optimize your attempt. If the supraglottic fails, going to bagging, and then going to cric if needed after that. But I thought it was interesting when going through these that most of them talk about trying to optimize as best as you can one of these other interventions, either using a BVM, a supraglottic device, or maximizing your intubation attempt. And then the last one in the true failed intubation pathway is going for a front of neck access or cricothyrotomy access for patients. The Difficult Airway Society, because it's more in-hospital based, does talking about like doing an emergency trach. That's not something we are going to do. That's more so if you have a trauma surgeon or some other general surgeon available to assist with that. But otherwise, they talk about the best way to go through a cric, which we will talk about shortly here. Questions on any of that so far, or comments? All right, so these are some of the typical examples of things that we would think of where you're going to have difficulty going through the mouth for patients. This is what most people think of as being why you would need a cric. This is actually a case that was flown by Air Care. There was a trauma patient that had crashed his car into a fence post.
I was on that run.
Were you on that run?
Morgan Township?
I believe so. So yes, there's a nice fence post in the mouth.
Wow.
Fun
It's a lot.
times. I bet that was absolutely wild. Like reading through that had to be insane. But going through some of the literature, these were the more common reasons you may need to go with front of neck access for airway management. Trauma is the biggest one. Everyone thinks about this. Their face is absolutely obliterated. One of the most common ones being a gunshot wound to the face, where people end up having the gun as it fires, it angles forward and distorts all of their oral anatomy. Unfortunately, a lot of us have seen it. Another one is patients that I don't think we think about as much, but oral or head and neck cancer can potentially distort all of the oral anatomy that makes it very difficult to proceed with intubation. Or because of, say, radiation to the neck or face, they may end up having some severe subglottic stenosis. So right underneath the vocal cord box, that makes it so it's hard to pass a tube going through the vocal cords. Angioedema and anaphylaxis are the ones on the bottom here. Usually most of us have seen the whole face that's puffy, the lips that are puffy, the tongue that is so big that you can't get anything inside of their mouth. The problem with this, though, is that in all of these, you can also then have edema of the larynx itself, which is this picture on, which is this picture here. So the actual larynx itself becomes edematous, including the epiglottis, the true and the false vocal cords. You can also see something like this in patients who have epiglottitis. That's not very common in the United States because we vaccinate against the bacteria that causes it, but it can be seen in patients who are coming from other countries or unvaccinated children. And with those, their epiglottis becomes significantly swollen, so much so that they'll actually tell us, ER docs, please don't try to intervene on this airway, have them go to the OR with ENT. So if anything goes wrong, they can convert it to a drink. And then the last one, which I don't think we always remember, is that patients who have significant obesity, this puts them at two problems. One, you have all this excess tissue that is edematous and excess in the neck itself. But then on top of that, the excess mass of their body makes it so it's very hard to oxygenate and ventilate them, because as your body's fighting against all of this excess tissue, it has to move, as well as all this excess tissue that it has to feed with oxygen and remove the waste products from. So oftentimes these patients will have short necks, a lot of excess tissue in the way, but on top of it, they won't have as long of a tolerance for apnea time, which makes it very challenging. When I was going through the literature, I did find some pre-hospital studies on actually doing crikes and found most of this from United States as well as outside the United States. This is a really rare procedure. The literature that I found showed that like over a 5-year period, you may have like 37 of these that happen in a country, whether all of the data from that whole country. There are some areas that do needle crike a little bit more commonly than a surgical crike, but both of these were taken into account. They're really rare, about like less than 1% of over all of the intubations. Most of these were successful. In one of the studies that I read, they had like a 97% successful placement of a crike performed by paramedics in a pre-hospital setting. Unfortunately, though, these are usually incredibly sick patients. Like the most common, one of the studies I looked at showed that the most common people that had the crike done were already in cardiac arrest or peri-arrest at that point when they proceeded with the crike. So there's already a high morbidity and mortality going into it. And most of the literature talked about that the hardest thing for people to do was decide to actually do the cut for patients. And one of the things that we'll talk about when you're looking at a failed airway discussion is that sometimes people will wait potentially too long when they've gone into the cannot oxygenate, cannot ventilate side of things before they will actually proceed with doing the crike for patients. And then that puts them even further behind the 8 ball from a metabolic standpoint for patients. So outside of like actually passing the tube, most of the time, the hardest thing for people was the decision to do the crike in the first place. Now, what most people will talk about is if you genuinely cannot oxygenate and genuinely cannot ventilate your patients, you have some justification for doing this procedure, especially if you tried everything in your wheelhouse that you can to try to fix it. And any EMSP actually came out with a statement that said that we support paramedics knowing this skill because in very significant cases, this can be beneficial to save people's lives. They talk about that BVMs and endotracheal intubation is still the mainstay way that we want to intubate people for obvious reasons. But it is justified and righteous for people, for paramedics to have this skill in an emergency situation where it may be needed. All right, so let's talk about the crike itself. Questions before we go on? Okay, so again, intubations is cannot oxygenate, can't ventilate, or cannot intubate patient, and then you have gone down to a true failed airway. So the anatomy itself, what you are shooting for is to make an incision on the cricothyroid membrane itself. This is usually the hardest part for people on doing a crike is remembering where the anatomy is at. How I teach it to my residents is you're going to find the thyroid cartilage, which is this thicker cartilage up top. That's also where people's voice boxes is. So if you feel it on your own neck and you try to phonate, you should feel that harder cartilage starting to vibrate underneath your finger. As you slide down, right underneath that cartilage, you'll find a little kind of divot. And that's usually where you'll have your cricothyroid membrane. So find that hard cartilage, slide your finger anteriorly and just slide it slightly down to where you have a slight divot. And if you push on that area slightly back towards your spine, it's going to feel obnoxious as heck because you're pushing at the very bottom part of your vocal cords. Some people talk about the difference between a cric versus a trach. A trach is lower down. On that one, our surgeons are usually going through like the third or second tracheal ring. And that is a more permanent location that people can place a front of neck airway. It's also in a more vascular location, which is one of the reasons it's not necessarily recommended for us to do. We'll talk when we pull up some of these other pictures, I'll show you why the cric can be a little bit better in the pre-hospital setting. But this all looks easy on a diagram. Next time you have a patient that you're transporting or just, I don't know, bored and hanging around for some reason, try to locate it on other people. When I teach this with interns and residents, I actually make them try to find it on me because I'm not super skinny, and that's a little bit harder to do it on a real live person who has a big head in the way versus just the little larynx model that most of us have that looks like this. Other things to be aware of in the front of the neck anatomy. So here is the thyroid cartilage, and right below it is going to be your cricothyroid membrane. Right in the middle of the neck, you will have some superficial blood vessels, but not a lot of significant vascular or neurostructures in that area. There is a lot of muscles though, as you see. The nice thing is that there is skin just kind of on top of that membrane and not of a lot of other tissue to cut through unless there's a lot of adipose tissue in that area. The one thing to be aware of though, part of what makes this such a bloody procedure is you have some of your anterior jugular veins that are right on the sides of this area. So if you extend that cut when you go through the cricothyroid membrane horizontally, you can hit some of those veins, which can make the procedure exceedingly bloody. So that's why people say you want to make a midline incision on the neck to avoid some of these other structures, and then just do a punch right through that membrane itself so that you avoid hitting some of these other blood vessels. So this is the laryngeal handshake that we were talking about a little bit earlier. This is how people talk about wanting to hold that anatomy once you find it. So you want to use your non-dominant hand. For me, I'm right-handed, so I would use my left hand. Find that thyroid cartilage with your thumb and your middle finger. And then once you find it, you're going to use your index finger to palpate that location and hold it. They call it the handshake just because you're actually holding it. You could potentially shake the cartilage a little bit. It feels funky, but you can't do it. The other thing too is once you have held that anatomy, don't ever let go of it with your non-dominant hand. That way your dominant hand, the one that is more agile, can be moving some of the other apparatuses while your left hand just sits there holding it. The one thing I don't like about this picture is most of the time you're gonna have your hand kind of like over the top of their face while you're doing this because their face is in the way, and you'll probably put a lot of the stuff that you need on the patient's chest. So just imagine that the hands that are here are like flipped on top of the patient to hold it in place. Things that can change the anatomy though. Adipose tissue we've talked about. One of the other ones though is extremes of age. So children, their cricoid tissue is smaller, and B is a little bit higher up in their neck as well. That's one of the reasons we don't do surgical crics on children as much. We do needle crics. It's a smaller caliber tube that you can actually get into that anatomy. And with it being higher up, you want to make sure that you're not damaging some of these other structures. Older patients can also have a little bit more mobile larynxes, and they can be a little bit more calcified as well, which can make them more challenging to palpate. One of the other things to consider is cervical length for patients, so neck length. So patients with a shorter neck, you will potentially have less anatomy to play with. And if your patient needs to be immobilized, one of the things that can be helpful in patients, if you can, is to tilt their neck up so you have more space to play with. But if you have a patient who has concern for a cervical fracture or cervical damage, you need to keep them immobilized, which does limit some of your space to play with in that area. So the actual procedure, this is discussion with the bougie and sixo endotracheal tube technique. And I have a couple of videos that I can play as well to show people with them. What you do for these is you're gonna find that anatomy with your left hand and hold it in place with your index finger over the cricothyroid membrane. Next, you'll take your scalpel and make a midline incision over the anatomy itself. The problem with this at that point is this then becomes a blind procedure. It's usually a ton of blood in this area, so you're very much dependent on feel. That is why you want to make sure your non-dominant hand is holding that larynx on for dear life. After that, once you made that midline incision, you're going to take your scalpel, turn it so that it's horizontal, and make a single stab incision right through that cricothyroid membrane. Right after you make that midline skin incision, you can use your finger to kind of dissect down through some of that fat tissue so that you know you're right on top of that cartilage itself. Once your scalpel has gone through that, people will talk about, and I think it makes sense, that once you have gained access to that hole, never have anything outside of that hole. So in the bougie method, what people will do is they'll put the scalpel through, and then you can slide a bougie down the back of the scalpel. So you have that tactile feedback of your bougie touching the scalpel as it goes into the neck. Some places will have a trach hook, which you can slide on the back of the scalpel and grab the cricothyroid cartilage. I like to go a little bit higher versus lower so that you can pull this up out of all of that bloody mess. But then that is inside of your hole, maintaining an apparatus for you to get access through. Another one is called a trousseau dilator. It's literally a three-pronged dilator that goes inside of the hole and spreads out, dilating it. Now, the nice thing about a trousseau is you can push a bougie through the middle of that trousseau, or heaven forbid an endotracheal tube. But once you get the hole, either with your scalpel, your trach hook, or your trousseau dilator, you then put your bougie through the hole itself, and then you can feed your endotracheal tube over the top of the bougie. And I think this is the video of someone doing it in real time. You guys see this, okay? We can use a finger as well if you need it.
It's that easy.
He's so supportive.
It's that easy.
Yeah.
Doesn't answer me.
What's that?
Didn't answer.
I know. We can scold him for that. Okay, so, and I have at the end of this, I have, my references have links to the videos for all this too, if people want it for future, entertainment or educational purposes, whichever. So the other option that, Woody was talking to me about is this, Pulmodine Control Cric Kit, which is the commercial device. We actually looked at this with Chief Whitty, and I didn't think it was a horrible device overall. The one thing that is nice about it is that the scalpel component also then becomes your holder for the airway itself. And this was their little trading video that shows how it works. After the ad. Thank you, we're good. I can't take the music, I'm sorry. And then in all of these, again, you're still gonna, the key part for all of this is identifying your anatomy. Once you've found it, you take your device. Make your midline incision. Turn it. Stab. Slide in the hook. Hook grabs onto the cartilage, then you can pull it out of the way. And you'll have that constant feedback of that cartilage actually being on the hook. Slide the device in, which has an introducer. Yeah. Take your introducer out. Inflate the cuff. And I would still advocate for these testing with waveform capnography, as it is the most accurate measurement to show that you are actually in the trachea. Because one of the biggest concerns we have with trachs is that there may be false passage. And then this is their little holder device. Hopefully no sea turtles get caught in it afterwards. And they make it seem so simple. There's your adapter. And then this slide device is used to help pull the adapter off. So that was the device that you guys carry. I think if there's one that's ever expired, it's probably worth pulling out to take a look at, just so you have a chance to play with the components yourself. And probably the biggest thing that I would double check if using that device in real life before you put it in a patient is make sure that that introducer is not completely stuck. Because oftentimes what happens with this type of technique where you have something that's sliding over an introducer, this part here, is that if this is too stiff, when you try to yank the introducer out, you may end up dislodging the device. So oftentimes what we'll teach people when they're doing something with Seldinger technique, that's where you have something placed over an introducer, either a wire or a large caliber tube, is that try to make sure that it slides a little bit before you push it into the human body. That way you make sure that you know how much pressure you need to use to pull it back out again. The biggest complications for doing a cricothyrotomy, bleeding is one of the biggest ones. And the reason we worry about that is that it can cause decent bleeding from the neck, could potentially lead to like a hematoma if it's deep, if the bleeding travels deeply, that can push on the airway itself. But more commonly, the problem that people run into is that that bleeding obscures their landmarks and makes it very hard for them to identify the anatomy. That's why it's so critical that we practice just identifying that anatomy on normal humans before you have to go in and actually do the cut. One of the other things too is if you have a chance to play with a mannequin where you can practice feeling that anatomy and feeling that membrane without skin over top of it, so you can understand what that feels like underneath your finger, that'll end up being your savior when you actually have to do this. The other huge complication that we worry about is a false passage. And this can be either the tube being placed too shallow or, God forbid, too deep. I actually know there was a case at UC a couple years ago where as part of the understandable doing this in a blind procedure and the panic of doing this procedure, they went too deep and ended up going through the trachea with the scalpel and then into the esophagus itself. So then when the endotracheal tube was pushed through, it ended up going into the esophagus. So then on top of having a disastrous airway from a blood, you now introduce a vomit into all of this and a second passage that may continue to contaminate the airway. The other thing that can happen for people is you can make it too shallow. So if you are putting your device through either the endotracheal tube, hook, whichever. If it gets dislodged as part of, or if you lose contact with that hole and you are not 100% sure that you are inside of the trachea itself, the endotracheal tube can pass through the subcutaneous tissues on the anterior surface of the neck. So in the video with the control kite they were talking about, there's a little coude tip or kink in the end of that introducer. So it's supposed to tent the skin right here. If you're using a bougie, you should be able to go until you feel hold up. And that should be within about, I'd probably say about 15 to 20 centimeters based on the location where you're going through in the neck. Or you may even be able to feel tracheal rings with that coude tip. We don't always feel them when we're doing a cripe just because that tip is not a severe enough of an angle so you can feel those rings on the tip of the bougie, but you may still be able to feel them. And that's one of the other reasons too, you want to confirm your placement with end tidal capnography to make sure that you have not gone in either too deep or too shallow. I found this article out of Britain where they actually interviewed a bunch of paramedics who had ended up doing crikes in real life in the field and talking to them about their experience. And these were successful crikes. And the biggest things that they found that surprised them out of doing the procedure was the amount of bleeding and that it truly is blind. Once the patient has their cut made on their neck, they end up not being able to see anything at all. And the other thing that was brought up, which I know the providers in this case, our case here in Westchester mentioned, is that the larynx moves. If the patients are not dead and are still breathing, their larynx may move up and down as they are trying to breathe and trying to overcome the airway obstruction that they have and their difficulty breathing. And this was seen, I thought it was interesting that that was seen also in multiple other paramedics who had done this procedure. And that's also why it's so critical that you maintain that grip on the larynx, so that if it moves, your hand moves with it, so you understand what's going on with the anatomy. If you want to imagine how much it moves, try to give yourself a little airway obstruction by like making a little strider. And feel your own cricoid or thyroid cartilage moving up and down in your neck. Mostly what's going to happen is you try to breathe, you're going to actually feel the voice box moving deeper down into the neck tissue itself. Less likely anteriorly, but you can feel that on your own self to understand what they may be doing when this happens. And then the last thing that people brought up is that they thought it was a little bit more challenging than they expected. Part of that being the decision to actually do the procedure itself, and then the stress of going through it and the concern about being in the correct location. But these were all done successfully, and just like in the other literature, it was advocated for. The other thing that was talked about in the literature was a discussion of using the bougie 6-0 endotracheal tube method versus a needle cripe versus one of the prefab kits, like the control cripe kit that we have here at Westchester Fire. Most of them said that the bougie endotracheal tube method was faster. There was not a superiority in regards to, one of the literature that I found said that there was not like a superiority in one versus the other. There was another one, I think this was the academic emergency medicine, that showed that trained providers had a little bit more success when they were doing it with the bougie. So the kits are still appropriate. They do show that they have successful placement rate. Bougie might eke them out just a little bit, especially in terms of speed. The one that was not loved in an adult patient was needle cripe. Hence why we try not to do that if at all humanly possible. They found that the lumens were super small. Oftentimes the anatomy was lost, but it is still advocated for in the pediatric literature. And later on in this year, once I actually can find some data on this, I think I'll go over that with people, because there is no discussion on needle cripes, like none whatsoever. So I will do a little bit more digging before we go over that one as another airway nightmare case for people. And that's what I have prepared. I'll happily take any questions, comments, or discussion points.
Woody, what were your thoughts when you were doing it?
So for me, in full transparency, and that's what I had told the docs, the numerous docs that I had talked to afterwards. Had I not had the opportunity to cripe 60+ fresh cadavers over a 6-year period, the decision would have been very difficult to make. So when she brought up the point about the trachea moving, literally as I was going with the scalpel, the trachea literally moved up. She had almost like a guppy breathing type of effort, with totally ineffective. And, but her trachea was still moving. So even though teaching it for 6 years, that was something I was never taught. So that's why I brought it up to bring it up. But yeah, the big thing is anytime that I've taught this, whether it's here, outside of here, downtown, whatever it be, people always say, oh, I can do that. And no big deal, right? It's not doing the skill. The skill is still a big deal. It's the thought process to make that decision. The crew performed phenomenally well. The plus for me was, two of the members there, I taught in the cadaver lab while they're in medic school. So as we were talking through this, between the two of them and, another one of our regular partners, then the lieutenant was from a different shift, but still performed very, very well, cause it was all hands on deck. So I called it out early that if we didn't get what we were going for, that we were going to cut, made sure everybody was in the same mentality. Which I think was huge for comfortability. And then by the time we got to that point, everything was opened up on our chest. I had plan A, plan B, and then we made it cut. But the big thing I want to reiterate is how well and how efficient the crew operated. Everybody was doing something for the betterment of the patient. Down to the point when she coded up, no pulse, went to a systole, compression started in 3 to 5 seconds. I mean, it was way better than I could have ever imagined, to be honest. But yeah, that's the big thing I want to reiterate. I'm talking to the docs in the hospital. To do a surgical crike as a paramedic, like, you really have to understand the significance that you're empowered to do with that. That's a 4th year resident skill for the physicians. So their 4th year as a resident is when they can perform this. So they've had tons more schooling than we had as paramedics, right? So this is a huge ordeal, to make that decision, but you have to be prepared to make it if you need to.
So was it a allergic reaction or was it the swelling was caused by the Heimlich, or we just don't know?
So unknown, the differential was an allergic reaction. We didn't find a bolus, but that could have been blown apart with airway maneuvers, CPR.
And the airway was already irritated from that
Yeah.
possibly, so, okay.
But there was a ton of, we'll say, angioedema / sub-Q emphysema.
She was having shrimp, right?
Yeah.
Yeah.
So there was shrimp on
So
her
it's not
flight.
something boring where you could be like, oh, maybe not, but.
So when we called this out, early on as a differential, like, her plate was sitting right next to us. We're in the dining room of this nursing home. So I called it out, and then we had a discussion as we were working through it, and everybody was giving their input. It was, the team effort was incredible.
Yeah, I really don't know. I think this, the swelling is probably a combination of a couple different things. Sometimes subcutaneous air can be pretty impressive as well. When we were talking about this, I was talking to you about back when I was in resident or something like that, and we're working a code in an ICU, and the guy ended up getting pneumothorax, maybe before, but certainly got exacerbated during the course of the code. And not only do you feel kind of crepitus in the chest, but like it tracked down all the way to the belly and into the scrotum. So like as this code went on, this guy's scrotum just got huge and huge and huge, and it was just all this tracking subcutaneous air. It's like, it's like, but like when we're thinking about like places where subcu air can go, we're thinking about like false passage rates and stuff like that. That is also on the differential. Now, you don't do anything differently other than troubleshoot kind of what your tube is, and that's kind of, I think, where all the exchanges came into place. If, and this is kind of going to my question, if you get the bougie at the 602 tube and it's hanging out like that, just leave it, and you're getting good air. I think that tube actually had some issues with it, so I think the definitive one was the last one. You know, it was just another way to kind of troubleshoot, but like, if that works, and this 602 tube is hanging out like from the neck, you know, 6-7 inches, but you're getting good and tidal, and you just put that balloon right beneath kind of where you need it to go, like, that is 100% definitive airway. That's a fine airway to maintain in place. But I'll reflect on a couple things you said, like setting the expectation early, that does help with the decision making. That really is the, I want to say the toughest part of this is challenging procedure as it is, but like that is really probably one of the toughest parts of this, is just making the decision to do it. But actually setting that expectation early for everyone around, and even if you don't have to go down that pathway, like that's, fine, like if you end up getting all the stuff out and you end up getting two from a VL, like, fine, no problem, but at least having like, rather than finding yourself in the situation all the way at the end of the algorithm and then being like, all right, well, let's find the kit, then you're multiple minutes into it, and if that's all hypoxic downtime, then that could be catastrophic, right? And so like, that's where we started thinking about like predicting like difficult airways and what our game plans is, because that, to have it laid out in front of you, that really does help with decision making. One just very logistical point that I wanted just to make, because you said it and it's in the video, but I want to be explicit. The first cut is that a vertical incision, and that's just to get kind of the anatomy exposed and some of those jugular veins like out of the way. And then actually you're stabbed into the airway itself is that horizontal. So it is two. There are techniques, and like there's so many variations. You can see so many different variations on this. That, it's just a single horizontal feature all the way down, but that does increase the risk of extending it out laterally, because you do find like a big enough hole as well. So just to kind of highlight the point that you already made, vertical to expose, horizontal to actually get in. Once you're in, it's like an IO, once you feel that release, it stops, you're not like into the side.
8148 Princeton Glendale Road, 8148 Princeton
That
Glendale
vertical
Road.
incision for the time of doing the freshman average and the time now in the field, that vertical incision is actually a pretty easy incision to make, vastly more easier than you would expect, because those membranes run vertical. So when you drop that blade into that, outside of coming through the skin, it pretty much drops right through.
How long would you say it took before you were completely blind in the procedure? How long until the blood just covered everything?
So with the commercial device, there wasn't much bleeding. When I pulled the commercial device out, went back in with the scalpel to make the hole a little bit larger for the 6.0 tube and the Fuji, is when we had the bleeding. And it was vastly more bleeding than you would anticipate. But that was my wheelhouse way of doing this. That's how I taught it downtown. So then, like Kelly was teaching, there's several different ways to do this. The way I've always learned and really preferred was utilizing your pinky, and that's where you drop into that hole. So that tactile feel, Noah Zimmer will tell you the same thing, because he switched the final one out. And that's how he learned it in the cadaver lab downtown. So once he felt it, he said, oh, yeah, we're good to go, because that feeling. So at that point, I couldn't see anything. It was total by tactile feel. I felt that Bougie used my finger as like a shoe shim, came in, 6.0 tube up and over, advanced the, or, inflate the balloon, pull the Bougie out, and we're good to go.
Yeah, just as long as something's in there,
Yeah.
whether it's scalpel, finger, Bougie, hook, trochanter, whatever you got, just especially one's kind of like blood gets flowing and then it's stored in, having some sort of passages where
We'll do a lot more hands-on training with this stuff too. A lot of times when you have a case like this, you need to cover it, because these don't happen often. So there will be a lot more training, hands-on wise, for this stuff coming. And I want it to be regular every year, and Trevor and I have had that discussion.
You come with the Craig.
You watch the video.
Sounds like one thing that I picked up on what you're saying is having plan A, plan B, and whatever plan you want to go to next, C or D. As somebody who was involved in a not successful Craig. And this is a long time ago, we didn't have plan B, plan C.
Sure.
Now we do. So having that A and B plan, C plan ready to go is critical.
Yeah, so as they were in the efficiency of the crew again, but as they were setting up plan A, I was setting up Plan B right in front of me. So then I went to Plan A, had Plan B all set up, went to Plan A. They were already cleaning the neck. They're like, hey, here, and then, yep, you're right, and then we went. Yeah, you're absolutely right, and I've taught this here before, I've taught this a lot of places, but airway management, one thing the hospital and the trauma bays and things like that do really, really well is calling out Plan A, Plan B, Plan C. Pre-hospitally for airway management, we don't do as good of a job of it, but it's not talked about as much as it should be, right? So that's not a fault on the provider, that's a fault of the education that providers get of having an understanding that you need Plan A, Plan B, Plan C. So, and normal airway. All right, my first attempt's in intubation, my second attempt's in I-gel. Okay, well, what size I-gel? Have it sitting out and ready to go in case you need it, it's right there. You see what I mean? So that progression of Plan A, Plan B, Plan C.
I got mocked last year in the shrew at UC because my tactic when I was doing airway backup for the second year residents is I'd always have a bougie in my back pocket. And the bougie was so much taller than I was, so it was this sticking out. What's that?
I love that though, that's awesome.
Oh, it's right there. That way if it was like really soil and I was like, but I can see it, damn it, if I just get this thing through there, it was like, here, move it, go. But that is one of the things we'll talk about, exactly like what he said is what people say is like, my plan is to go in with a MAC 3 with a 7.5 ET tube. I'm gonna do this to prep them, like I'm gonna do a shoulder roll, I need the bed lowered and other positioning as much as you can, but the benefit of the hospital is we can move all the crap all over the place, but you can't do that when they're stuck between the toilet and the floor as much. But you'll say like, this is my initial plan, I have a bougie as, if I have a bunch of secretions, I have a bougie as well as a decanto and double suction setup. That's one of the other things I talked about in the Crike literature is have some suction ready, because if you have another set of hands, you can say, hold this section so that you can pull some stuff out of my way. It might help a little bit and also keep blood out of the lungs, which is caustic. But we'll say like double suction, I'm gonna have a bougie in case I lose my view or have a unanticipated difficulty with view. And then my backup is an eye gel. Or like, I think another one that people say is gonna do a hyperangulated blade. But then if we need to, we will put an eye gel and then swap out to fiber optic. But we can do that in the pre-hospital setting of like, I think this is gonna be standard anatomy, intubation. If there's a problem, I'm gonna put an eye gel in as a backup, and we're gonna bag them up with that using a PEEP valve to get them oxygenated. And then look at the next attempt, which we may swap to a bougie, we may swap to direct, we may swap to a Miller even, I mean, it's whatever, it's just taking a look at the patient and trying to anticipate some of the difficulties you run into. Or if you have a failure, or a failed attempt, that is a moment that's why part of they say in the difficult airway discussion is stop, look at what went wrong and how you can troubleshoot that. What devices, positioning, medications, preparatory work you can do to try to overcome that on the next attempt.
Yeah, I agree. If you ever find yourself in a situation where I would just in a tracheal, an attempt that you can't pass the tube, like change something, any of the things that you just mentioned.
Tube size even.
Tube size, position, blade, operator, any of the above. So you're changing something about that, the attempt. But if you end up, even before launching into it, before kind of into this pathway, like vocalizing, so we have a shared mental model of everyone that's seen. You guys do a really good job of this, like for critical care. We rarely find ourselves in this right position, and so being even more explicit about that to kind of everyone who's around and say, all right, this is kind of going to be our pathway here. Really does kind of set up.
Yeah. Did you have any other questions, Scott?
Nope.
Anyone else have questions?
You can ask other houses if there's any questions.
Guys, other houses got questions? I can see 75 sitting and watching and 73.
If not, we can.
Yeah.
Okay.
Cool.
Thank you, guys.
All right, cool. Thank you.
I mean, way to time it coming in.
It is.
You have your glass, listen to the door. Okay.
You slow rolled us.